Aortic dissection occurs when a tear in the tunica intima of the aorta causes blood to flow between the layers of the wall of the aorta, forcing the layers apart. In most cases this is associated with severe characteristic chest or abdominal pain described as tearing in character, and often with other symptoms that result from decreased blood supply to other organs. Aortic dissection is a medical emergency and can quickly lead to death, even with optimal treatment. As a result of decreased blood supply to other organs, heart failure, and sometimes rupture of the aorta. Aortic dissection is more common in those with a history of high blood pressure, a known thoracic aortic aneurysm, and in a number of connective tissue diseases that affect blood vessel wall integrity such as Marfan Syndrome and the vascular subtype of Ehlers-Danlos syndrome. The diagnosis is made with medical imaging. The treatment of aortic dissection depends on the part of the aorta involved. Surgery is usually required for dissections that involve the aortic arch, while dissections of the part further away from the heart may be treated with blood pressure lowering only. Since the 1990s, endovascular aneurysm repair has been used in specific cases. Aortic dissection is relatively rare, occurring at an estimated rate of 2–3.5 per 100,000 people every year. It is more common in males for unknown reasons. Mean age at diagnosis is 63, although all age groups may be affected. Many cases of aortic dissection lead to death so rapidly that the person does not reach a hospital in time. The first case of aortic dissection described was in the post-mortem examination of King George II of Great Britain in 1760. Surgery for aortic dissection was introduced in the 1950s. Signs and symptoms. About 96% of individuals with aortic dissection present with severe pain that had a sudden onset. It may be described as tearing, stabbing, or sharp in character. 17% of individuals will feel the pain migrate as the dissection extends down the aorta. The location of pain is associated with the location of the dissection. Anterior chest pain is associated with dissections involving the ascending aorta, while interscapular pain is associated with descending aortic dissections. If the pain is pleuritic in nature, it may suggest acute pericarditis caused by bleeding into the pericardial sac. This is a particularly dangerous eventuality, suggesting that acute pericardial tamponade may be imminent. Pericardial tamponade is the most common cause of death from aortic dissection, while the pain may be confused with the pain of a myocardial infarction. Aortic dissection is usually not associated with the other signs that suggest myocardial infarction, including heart failure and ECG changes. Individuals with aortic dissection who do not present with pain have chronic dissection. Less common symptoms that may be seen in the setting of aortic dissection include congestive heart failure, fainting, stroke, ischemic peripheral neuropathy, paraplegia, and cardiac arrest. If the individual had a fainting episode, about half the time it is due to bleeding into the pericardium leading to pericardial tamponade. Neurologic complications of aortic dissection are due to involvement of one or more arteries supplying portions of the central nervous system. If the aortic dissection involves the abdominal aorta, compromise of the branches of the abdominal aorta is possible. In abdominal aortic dissections, compromise of one or both renal arteries occurs in 5 to 8% of cases, while mesenteric ischemia occurs 3 to 5% of the time. Blood pressure. While some patients with an aortic dissection have a history of hypertension, the blood pressure is quite variable at presentation with acute aortic dissection, and tends to be higher in individuals with a distal dissection. In individuals with a proximal aortic dissection, 36% present with hypertension, while 25% present with hypotension. In those who present with distal aortic dissections, 70% present with hypertension while 4% present with hypotension. Severe hypotension at presentation is a grave prognostic indicator. It is usually associated with pericardial tamponade, severe aortic insufficiency, or rupture of the aorta. Accurate measurement of the blood pressure is important. Pseudohypotension may occur due to involvement of the brachiocephalic artery or the left subclavian artery. Aortic insufficiency occurs in half to two-thirds of ascending aortic dissections, and the murmur of aortic insufficiency is audible in about 32% of proximal dissections. The intensity of the murmur is dependent on the blood pressure and may be inaudible in the event of hypotension. There are multiple etiologies for AI in the setting of ascending aortic dissection. The dissection may dilate the annulus of the aortic valve, so that the leaflets of the valve cannot coapt. Another mechanism is that the dissection may extend into the aortic root and detach the aortic valve leaflets. The third mechanism is that if there was an extensive intimal tear, the intimal flap may prolapse into the LV outflow tract, causing intimal intussusception into the aortic valve, preventing proper valve closure. Myocardial infarction occurs in 1 to 2% of aortic dissections. The etiology of the infarction is involvement of the coronary arteries in the dissection. The right coronary artery is involved more commonly than the left coronary artery. If the myocardial infarction is treated with thrombolytic therapy, the mortality increases to over 70%, mostly due to bleeding into the pericardial sac causing pericardial tamponade. Because aortic dissection may present to the emergency room physician similar to a myocardial infarction, the physician must be careful to make the proper diagnosis prior to initiating treatment for myocardial infarction, since the treatment regimen for myocardial infarction can be lethal to an individual presenting with aortic dissection. Pleural effusion. A pleural effusion can be due to either blood from a transient rupture of the aorta or fluid due to an inflammatory reaction around the aorta. If a pleural effusion were to develop due to an aortic dissection, it is more commonly in the left hemithorax rather than the right hemithorax. Causes. Aortic dissection is associated with hypertension and many connective tissue disorders. Vasculitis is rarely associated with aortic dissection. It can also be the result of chest trauma. 72 to 80% of individuals who present with an aortic dissection have a previous history of hypertension. A bicuspid aortic valve is found in 7 to 14% of individuals who have an aortic dissection. These individuals are prone to dissection in the ascending aorta. The risk of dissection in individuals with bicuspid aortic valve is not associated with the degree of stenosis of the valve. Marfan syndrome is noted in 5 to 9% of individuals who suffer from aortic dissection. In this subset, there is an increased incidence in young individuals. Individuals with Marfan syndrome tend to have aneurysms of the aorta and are more prone to proximal dissections of the aorta. Turner syndrome also increases the risk of aortic dissection by aortic root dilatation. Chest trauma leading to aortic dissection can be divided into two groups based on etiology: blunt chest trauma and iatrogenic. Iatrogenic causes include trauma during cardiac catheterization or due to an intra-aortic balloon pump. Aortic dissection may be a late sequela of cardiac surgery. 18% of individuals who present with an acute aortic dissection have a history of open heart surgery. Individuals who have undergone aortic valve replacement for aortic insufficiency are at particularly high risk. This is because aortic insufficiency causes increased blood flow in the ascending aorta. This can cause dilatation and weakening of the walls of the ascending aorta. Syphilis will only potentially cause aortic dissection in its tertiary stage. Pathophysiology. As with all other arteries, the aorta is made up of three layers: the intima, the media, and the adventitia. The intima is in direct contact with the blood inside the vessel, and mainly consists of a layer of endothelial cells on a basement membrane. The media contains connective and muscle tissue, and the vessel is protected on the outside by the adventitia, comprising connective tissue. In an aortic dissection, blood penetrates the intima and enters the media layer. The high pressure rips the tissue of the media apart along the laminated plane, splitting the inner 2/3 and the outer 1/3 of the media apart. This can propagate along the length of the aorta for a variable distance forward or backwards. Dissections that propagate towards the iliac bifurcation are called anterograde dissections, and those that propagate towards the aortic root are called retrograde dissections. The initial tear is usually within 100 mm of the aortic valve, so a retrograde dissection can easily compromise the pericardium, leading to a hemocardium. Anterograde dissections may propagate all the way to the iliac bifurcation of the aorta, rupture the aortic wall, or recanalize into the intravascular lumen, leading to a double-barrel aorta. The double-barrel aorta relieves the pressure of blood flow and reduces the risk of rupture. Rupture leads to hemorrhaging into a body cavity, and prognosis depends on the area of rupture. Retroperitoneal and pericardial ruptures are both possible. The initiating event in an aortic dissection is a tear in the intimal lining of the aorta. Due to the high pressures in the aorta, blood enters the media at the point of the tear. The force of the blood entering the media causes the tear to extend. It may extend proximally or distally, or both. The blood will travel through the media, creating a false lumen. Separating the false lumen from the true lumen is a layer of intimal tissue. This tissue is known as the intimal flap. The vast majority of aortic dissections originate with an intimal tear in either the ascending aorta, the aortic arch, or just distal to the ligamentum arteriosum in the descending thoracic aorta. As blood flows down the false lumen, it may cause secondary tears in the intima. Through these secondary tears, the blood can re-enter the true lumen. While it is not always clear why an intimal tear may occur, quite often it involves degeneration of the collagen and elastin that make up the media. This is known as cystic medial necrosis and is most commonly associated with Marfan Syndrome, and is also associated with Ehlers-Danlos syndrome. In about 13% of aortic dissections, there is no evidence of an intimal tear. It is believed that in these cases the inciting event is an intramural hematoma. Since there is no direct connection between the true lumen and the false lumen in these cases, it is difficult to diagnose an aortic dissection by aortography if the etiology is an intramural hematoma. An aortic dissection secondary to an intramural hematoma should be treated the same as one caused by an intimal tear.